Okay, so it's 10:05, so we're gonna start.
Mhm.
I'm just gonna quickly introduce myself and then Ying will introduce the first speaker. So I am Megan Bennett. I am the public health academic coordinator for the Public Health Coalition. Again, welcome to our series. We're restarting it, fall 2023 seminar series, and basically it's just to allow researchers and faculty and staff collaborate and communicate on different public health issues or what they're researching on. So again, we're very happy that you guys are here, and if for some reason you do need to step out, this is going to be recorded and shared on our website. So thank you again, and Ying, you can introduce the first speaker.
Yeah, thank you, everyone. I'm going to introduce our first speaker, Dr. Yan Zhang. She's associate professor from School of Information. She received, her master from University of Tennessee and PhD from University of North Carolina at Chapel Hill. She is the expert on consumer health information system. She studied by looking at the users' perceptions of information system, especially web-based information retrieval system about consumer health. She also do consumer health information needs and information seeking, and also the design of consumer health information system. So now let's welcome Dr. Zhang.
Thank you, Ying, for the kind introduction. So I actually prepared the slides for it. So can I share my screen now?
Yes, you can just share screen.
Share it now.
Okay, share screen.
Yes, we can see your screen.
Okay, so thank you. So as you
now I think we see your presenter mode. It's a mode that you see on your own. It's not fully on the presenter. So I will see two slides now on your screen.
And show, and let me start again.
Yeah. Okay.
Good now.
So you have next slides next to each other. Go upper left corner, right? Where's the up left corner?
Let's see.
Up left corner.
Swap displays.
Swap displays.
Share screen. Desktop 2. This should work.
Okay, that works.
Okay,
Thank
great.
you.
Thank you. So as you introduced, I study consumer health information search behavior. So generally, how people search for, make sense of, and use online information systems like search engines and social media to support their health goals. I also design information architecture and information environments that facilitate people to access high quality health information. So today I'm going to share our work on one of the important steps in the health information search process is consumers' evaluation of the online health information quality. So searching for health information online is a public health behavior. More than 80% of the internet users in the US look on the web for health information. The information found online has significant impacts on many health behaviors, such as treatment decisions and compliances, patients' attitudes towards disease and coping, sense of control, disease management, as well as preventative behaviors such as eating and exercising. So web as a consumer health information environment is vast and also complicated. It provides many information sources to health information, including search engines like Google, and various websites, including commercial websites, government websites, hospitals and clinics, and a lot of new user-generated content websites like online health communities, and more recently, social networking sites. The recent appearance of generative AI tools like ChatGPT provides another access point to health information for consumers. So facing these many options online, and we're constantly overloaded by information. And it's very often that we encounter conflicting information online, which disturbs our sense-making, our learning, and as well as decision-making. So in recent years, misinformation becomes rampant, particularly on social media platforms. So beyond all these problems, hundreds of studies showed that consumer health information varied widely in its quality from place to place. So this information environment or this situation leaves it is consumers' work to discern the quality of online health information before they can effectively make use of the information to support health decision-making. So how we define quality? Quality, I mean, as many other concepts, is defined very differently by researchers. But generally speaking, people define quality as accuracy, trustworthiness, believability of information, or information's fitness for use. So quality evaluation remains a major challenge for health information consumers today. So around this research problem space, our research group tackled it mainly around 3 research questions. The first is, how do consumers evaluate the quality of online health information? Second is, what factors affect their evaluation behavior? And third is, how can we improve consumers' ability to evaluate information quality? So to address the first question, how consumers evaluate information quality, and we conducted a systematic review analyzing 37 peer-reviewed articles where participants described how they evaluated online health information. So the evaluation criteria or behavior was not imposed by researcher, instead articulated by participants themselves. So we identified criteria and indicators that people use to help them evaluate information quality. So criteria are qualities of information that people value. Like, for example, its objectivity, its accuracy. Indicators are observable attributes or properties of information objects to which criteria are applied to form judgments, such as like publication date, like source, and design, like look and feel of a website. Okay. So we find that consumers use a wide range of criteria and even wider range of indicators to help them form judgment of information quality. So the most frequently reported criteria are intrinsic qualities of information, including trustworthiness, expertise, and objectivity. So the fourth one is transparency. It is an ethical dimension of quality, and followed by popularity, which is a social measurement of quality. And the last one is understandability, which is very contextual, differ for different person. The most frequently reported indicators used, the top one is related to source, it's site owners or sponsors, and followed by 4 content properties. So including consensus among multiple sources, characteristics of writing and language, advertisement, and content authorship. So the last one is interface design factor. So around the second research question, what factors affect their evaluation behavior? We studied 2 factors. Both factors are either empirically or theoretically important. So one is information source and the other is e-health literacy. So our research question was, how do information sources and e-health literacy affect people's use of indicators and criteria in evaluating the quality of online health information? So we conducted a lab experiment involving 25 participants, reviewing 15 web pages from 3 kinds of different sources: government, commercial, and online forums. So we annotated these 15 web pages. We annotated out their quality indicators. So an example of the annotation is shown in the screenshot. So in the experiment, we used eye tracking to track the eye movements while participants are reviewing this website. So we evaluated their e-health literacy by the e-health scale. Okay. So here is the results. The table shows the use of indicators and criteria across these 3 types of sources. So C refers to content factors, S refers to source factors, design refers to, D refers to design factors. So the greater than sign indicates that the results are statistically significant. So here we see that the use of indicators and criteria across these three types of sources, they share some similarities. So content indicators and criteria we used the most across all three kinds of information sources: commercial, government, and online forums. So source indicators and criteria were used more often than design indicators in evaluating government website and online forums, but this behavior didn't show with the commercial websites. So the design indicators and criteria were used the least across source types. E-health literacy did not significantly affect the use of indicators and criteria. So both the results of both studies counter the intuition and some large-scale empirical studies that people primarily use design factors to form quality judgment. So both of our studies actually show that people care about content and source much more than design. Second, consumers care most about health information content and source, their intrinsic quality, including trustworthiness, expertise, and objectivity. So surprisingly, e-health literacy did not affect participants' use of quality indicators and criteria, so which invites future research to investigate if it affects people's interpretation of the indicators and criteria. Okay, so around research question 3, how can we improve consumers' ability to evaluate information quality? We conducted an intervention study where we designed and evaluated a page graph. So page graph is intended to be a Chrome extension that will automatically extract quality indicators from a current web page. As shown in the interface on the right side of the interface, so this is a page graph. And on the left side of the column, there are indicators. So like site owner, sponsor, contact information, site type, and authors. So this selection of indicators are based on our previous systematic review results on consumers' use of quality indicators. So this is evidence-based. So the right side of the table shows that the current value of each indicators associated with the current website. So through this design, we try to help participants or help users to identify and see the quality indicators while they are browsing the website. So the page graph design is also informed by the nudge theory, so which means that the page graph is intended to be changing participants their information environment, but without being intrusive and without interrupting their natural information search process. So participants can also choose to close or open page graph at their will. Okay. So this table is a more close view of the indicators being included in page graph and their definitions. So we conducted the evaluation of page graph, both qualitative and quantitative. So the qualitative evaluation with 16 participants showed that for some participants, it enhanced their evaluation efficiency by providing easier access to the indicators that they were already familiar with, because it saves time for them to find it out from the web page. For some participants, page graph enables more and sometimes fresh angle to access information ability or quality. So page graph provides like new indicators for them to study, to learn. And for some participants who do not know how to begin their evaluation, page graph actually provides a framework to guide their evaluation. And for other participants who have the habits of evaluating information quality, page graph serves as a verification tool. So help them to verify their judgment after they form their own judgments. But unfortunately, the quantitative evaluation with 60 participants showed that participants, regardless of their e-health literacy, did not differ in their evaluation of a set of web pages with varying quality. So indicating that page graph did not significantly influence evaluation outcomes. So this provides us some opportunities for future research. So in the future, we're going to continue to explore different structures and content of the nudge we implemented, like, for example, making the nudge more explicit and actionable to see if they will help improve user behavior. And in the future, we're also going to look at how consumers evaluate the quality of information in other modalities, such as videos, given the popularity of videos, particularly among young generations of consumers, and information generated by generative AI. We are going to also explore interface-based approach to help users evaluate the quality of information in various modalities. Okay, here are some references, and I want to thank my collaborators, including my colleagues and students. Thank you very much for the opportunity to present the work here. Thank you.
Thanks, Ian. Any questions? We have time to pick up a couple of questions.
I have a question.
While we're waiting, I have a question. So you talk about the page graph. Is the page graph generated by your tool, or page graph is already existed? That for each website you can generate page graph. Is a software? Mm-hmm.
It's intended to be a software. So before we go about developing it, we want to evaluate the efficacy, how effective it is before we actually go about for the development. So the evaluation used in the study is mock-up systems. So it's yes, yeah. So we use like a JSON and HTML to mock up the system.
Mm-hmm. Thanks.
Can you guys hear me? I wasn't sure if you're able to.
Megan, you want to say something? I think I cannot hear you.
Yeah,
okay.
I just had a quick question. On the I think it was like the second to last page you mentioned, I was just curious, did your research uncover any differences in consumer evaluations of healthcare quality between like various online platforms? And do you find that maybe the younger generation is gravitating towards it?
The younger generations, what I mean is the younger generations are more gravitated towards consuming videos. I mean, these days, short form videos like TikTok videos, and then sometimes the short form videos leading to long form videos like on YouTube. So we are interested in looking at how consumers are reacting to video information, because it's more engaging, more immersive, and emotionally, it's actually creating more connections between consumers and information producers. So we kind of want to explore this rich space in terms of how people, like under this many psycho and emotional influences, how they make a judgment objectively of the information quality they receive. And then plus many of their like diet and exercise behaviors are influenced by the online videos from like influencers primarily.
Great, thank you.
Yeah.
Then maybe if we don't have any question, we can move to next speaker.
Okay.
Thank you, Ian.
Thank you all.
Thank you.
Thank you.
Our next speaker from the Cockrell School of Engineering, we have Dr. Edward Castillo, who's an associate professor and associate chair of graduate education in biomedical imaging and instrumentation. He received his Bachelor of Science in Mathematics from St. Mary's University in San Antonio and was a graduate of the university's honors program. After receiving his PhD in CAAM from Rice University, Dr. Castillo completed a postdoc fellowship in mathematics at the University of California, Irvine. Prior to joining the UT BME faculty, Dr. Castillo was an assistant professor of radiation physics at UT MD Anderson's Cancer Center and an associate professor of radiation oncology at the Oakland University William Beaumont School of Medicine. Dr. Castillo's research program is focused on the theoretical development, implementation, and clinical application of numerical methods for medical image analysis. Please welcome Dr. Edward Castillo.
Thank you, Jay. That was very good. I appreciate the warm introduction. So excuse me. Those four letters, CAAM, that stands for Computational and Applied Mathematics. And I'll just point out that that's not the same thing as the math department. Math department was in natural science. My degree came out of the School of Engineering. And I did spend most of my early years before coming to UT in academic hospitals, and that drives a lot of the research that I do. So today's not too deep. It's more on the superficial side, just to give you everyone an idea of what I'm up to. I'm still relatively new, I would say. I joined in 2021, so I'm open to collaborations. I'm always looking for them. So if any of this grabs your attention, please let me know, and we can talk about it some other time too. So my lab is called the Dynamic Medical Imaging Computing Lab. You look at the picture here, I think you get the idea. So I watch stuff move around and then try to say something intelligent about the thing that we're watching move. Typically it's a heart, sometimes brains and lungs breathing. And then you can infer something functional about what's happening underneath. And then that has a benefit to the patients downstream. So I got my start in radiotherapy. And so for those, just a quick crash course on how this works. If you haven't seen it, this is for cancer therapy. So you need to put radiation into a tumor. What happens is the patient lays here on the table. This thing can rotate. This is a linear accelerator. The source is back here. Radiation comes out. If you're laying on the table, you look up, you see this thing here on the left. That thing can rotate, take different shapes, and based on all those degrees of freedom, you can make these really conformal dose distributions that will paint the target hot while satisfying some sort of safety constraints on the critical organs. Like, if you have lung cancer, that's what I'll talk about here in a second. Then dose goes into the tumor, but you want to minimize dose to the lung, or you want to minimize outside, the healthy lung to the heart, esophagus, and things like that. And so if I turn the dose distribution, the way the radiation was delivered, into an image, it looks something like this. You can see the target was here in the center. And then all these you can see beam angles, because this thing rotates and you can make all these shapes. And it looks really, really tight. So there's lower dose, out here, but then in the intersection, that's where all the dose went. That's where the target is. So in order to do that, there's safety constraints that are applied to all those critical organs, and then a prescription dose that has to go into the tumor. So back when I finished my postdoc at Irvine and I went to MD Anderson, this is the first thing I saw, and I've been using this slide for a long time. So this happened a long time ago, but on June 14th of that year, a patient came in for radiotherapy for esophageal cancer, had this dose distribution here. Everything was fine. It was a unextraordinary, just regular, ordinary type of treatment. What ended up happening is on July 30th, they came back to the hospital with respiratory distress. And then on the 2nd of August, they died. And they have this picture here. And so you see this out here, if you're familiar with CT scan, it's kind of related to the density of the material. So normal lung tissue will be darker because it's primarily got air in it. Well, so this white stuff showing up there, it's looks like concrete. This is fibrosis, or it's radiation-induced pneumonitis. It's inflammatory response to the radiation. So this person had esophageal cancer. Their lungs had a horrific response to the radiotherapy, and they died from that. So that it wasn't, I know, and of course, people, cancer is bad, and you could take chemotherapy, you lose your hair, there's side effects to these things, that. But for me, it just seemed like I couldn't believe it that this person had esophageal cancer, and then their lungs killed them because their lungs were too sensitive to radiation. And so back then I thought, well, is there anything I can do to help with that? And I'm not a physicist or a clinician. So it's like, well, I know how I can do image processing. I wonder if that'll help. And so I've been pretty much doing that ever since. So that's the introduction. I'll talk about one of the main things I've done up to this point, and then some of the applications I'm up to and directions I'm taking it. If anyone has a question, feel free just to chime in. All right. So first of all, the radiotherapy is just delivered, and that safety constraint I said on the lung treats the lung, any part of the lung, not tumor, is just as important as any other part of the lung. But so this part is just as important as that part, and that makes sense. I mean, you would think that would be the case. But as you look here, this is a ventilation image. This is single photon emission computed tomography. patient inhales a radioactive tracer, and you pretty much image where the gas distribution goes throughout the lungs. And so if there's a place that shows up cold, then that means no gas went there, and that you can assume then that there's no ventilation in that region. So if you look at a picture like that, you think, well, there does appear to be some parts of the lung that are more important than others. That's hard information to get a hold of prior to a treatment plan, though. When the patient's going to get treated with radiotherapy, this type of information is not standard of care and not always available depending on where the clinics are and such. But this is ventilation. You can do the same thing with perfusion. And so this is the perfusion. You see this cold spot over there, that's a tumor. And so that is a definite defect that's occurred because of the disease. And so if you realize this and you say, well, if I knew which parts of the lungs were more important than the others, then maybe I could devise a better treatment plan specific to this patient. Right? Problem is, like I said, these images aren't really standard of care, and the ones that are available are not that great. So you see this really bright spot up here. That's, you don't have ventilation, your airway doesn't breathe. This is a trachea. There's no air exchange, not happening. There's no blood gas exchange or anything. That's just that the aerosol was water soluble, so it gets deposited in the airway. So it's not ventilation. It's gas distribution that is, because it's water soluble, shows up very hot. So the takeaway from this is that these bright spots don't necessarily mean ventilation, but if there's a cold spot, then you can infer that there's no ventilation. Does that make sense? I saw these things. So these are 40 CT, standard of care for lung cancer and thoracic radiotherapies, and it's a tool for tumor motion management. So I saw those things walk, around, and I saw that current ways to image lung function were not that great, especially when it came to radiotherapy. And I said, is there something I can do with this, I wonder? And that led to this, what I would call, I guess, an imaging modality. It's an image processing based modality called CT-derived functional imaging. Started developing when I was back at MD Anderson. And the gist of it is you watch the lungs breathe. And like I said, you can relate the CT scans back to somehow, you can relate it kind of with material density. And so if I watch the lungs breathing, I can see them change shape. So I change volume, and I can see them change density. And volume times density gives you mass. And so between all these things, this, basic physics and modeling, the idea was to take this image, do image processing, and then infer lung function from the 40 CT. That was the whole point. And so this is how it works. There's the 40 CT comes in. There it is. Looks great. Then you have to do image processing. So the first thing I want to do is if I want to say something about the lungs, I have to find them in the image. And that's this process called image segmentation. This is right here. The workhorse of this right now is deep learning. So I have a dense net that does this at the moment. The next thing, though, is I need to be able to track tissue motion, lung motion across the breath cycle if I'm going to say something about what's happening underneath. And so that is a separate image processing problem here. So you can see the vectors. The vectors, the base of the vector is the position of the tissue at inhale, and the tip of the vector is watching that piece of tissue float around through the breath cycle. Now, how do you go about getting that? Well, that is a numerical optimization problem. And so I learned that at CAAM, the CAAM. And so I use a lot of applied mathematics as under the hood. This is a particular challenging optimization problem. And that's how that works. So this vector field that got computed, there's a lot under the hood there, sweeping under the rug. All right, then based on all that information, so segmentation, motion management, or motion recovery, all of that, combine it together, do some basic physical modeling, and I can convert that moving image into this color-coded image. As this color-coded image says, if the place is dark, then that's, I'm saying, is low function. And then the dark red, the higher red colors, that's high function. And so now, using a standard of care 40 CT, I'm able to compute these ventilation images that I'm saying that relate function, patient-specific function that can then be used, incorporated into their treatment planning process. And so this was all the rage a couple of years ago. So that's in 2019. This is the cover of Medical Physics. I just want to point out that it's still actually a thing. So people still try to do better than I do when it comes to computing these things. I'll point out that for the math inclined in the audience, computing volumes is a lot harder than it looks. And that's what this ventilation image is doing. It's just taking this region at inhale, it changes volume at exhale. What's the difference in the volume change? And that's going to somehow infer how much air went in and out. The sounds pretty simple, but like I said, the framework for doing this was it's not straightforward. There's a lot under the hood, and it was well received in the physics community. And so back to the original application for radiotherapy, the 40 CT is standard of care, so they already get those images. And now all you're doing is you're putting that image goes through one more step to a computer that does image processing, computes these ventilation fields for you. So that was the whole the benefit is that you can make ventilation now out of standard of care. Patient doesn't have to get any extra imaging, anything like that. So minimal disruption of the clinical workflow, right? We had an R01 study where we tested this out on the original problem, which was for reducing the incidence of radiation pneumonitis. The thinking being that if I knew which parts of the lungs are more valuable than the others according to function maps like this, then I can devise radiotherapy plans to avoid the parts of the lungs that were highly functioning at the expense of the parts that are not. And so this is a clinical plan here. This is the ISO contours. So as the colors get brighter, that means more dose within the contour. You see that there's this magenta here, okay? And then underneath, the superimposed is the ventilation image we computed, right? So here's this functioning region that the arrow's pointing to. This is the plan that would have been delivered. But we said, no, try not to hit this part. And so they went and replanned. And now look at the magenta curve, you see? So it's missing the green part. So you don't hit the functioning part, okay? Try not to do that. And it makes a difference. And so you can grade pneumonitis response. I think 0 is nothing, 1 is symptomatic, but you don't do anything about it. Grade 2, you can quantify because that's when it starts to be treated. We get steroids. And so we were able to do 67 patients. We reduced in that study the incidence to 15%. The historical rate is 27. So it made a difference. And so at the next R01, this one here, this is to implement it. So to make a software grade version of all of this, it's push button. So you don't have to rely on me or somebody who knows what they're doing on the computer to create these images. You push button, the images come up, and then they can be used in regular treatment planning process. And we want to make this the standard of care. And so far, the clinical studies we've done, ours, and then other people have tried to support that, support this. Hopefully it's going to happen. All right. For the research components of that, so that's established, and now it's more about moving it into the clinic on a regular basis. On the research side, so that we got to 15% grade 2 pneumonitis incidence on 67 patients, which is terrific. But can you get better than that? And so it didn't always work, is the point, right? And so to me, I have these two plans here, right? There's a clinical plan and a functional plan, and that means there's two inputs, and the output function is patient function, patient lung function. And so that if I use this plan, the patient's lung function is going to be X. And if I use this plan, it's going to be Y. And then Y is better than X or something like that. So if I can manipulate the dose distributions, then maybe, and if I can predict what the lung function is going to be after the dose is delivered, then I can optimize it. And so the next line of research is then, well, let's, I'm doing this thing that's functional avoidance, and it makes sense intuitively what I'm up to and what we're trying to do, but maybe there's a better way. And so using, AI strategies, you take the input 40 CT, and then we start trying to predict what's going to happen post radiotherapy. And if you can do that, if you can predict, see, this is an input that comes in, this is the input that comes in, I can predict what the function is going to be, then I can fiddle with this and optimize it so that I can make the best output function or the best lung function post radiotherapy. That's the general idea. And we have a study with the Odin Institute. It's a pilot study with MD Anderson where it's retrospective. We're getting some data and we're going to try this thing out. I left out the perfusion part, but so for volume changes, ventilation, the changes in mass, so you can show that a lung changes weight as a person breathes, which is, it sounds like, well, that doesn't sound right. And it's not in a way, because the lung isn't necessarily changing weight, but in the image, the amount of blood in it is changing. So that the blood distribution changes as a function of breath. And if you can quantify that, then you can kind of infer where blood is flowing and use that as a surrogate for perfusion. So we've done that. And you can see this is a COPD. So here's an image, a color-coded one. It's not ventilation anymore. This is what I'm saying is a surrogate for perfusion. Here's somebody, gold is the way it's disease is quantified. Gold 1 is early stage disease. Gold 4 is pretty late stage. And you can see this person is, gold 1 is fine, or that has some defects occurring, these weird shapes, but then gold 4, there's nothing happening. This person is very sick. And you can quantify that across disease stage. Right. So that one's for quantifying disease. Predicting if someone are identifying disease is also my applications. And so here's the someone with pulmonary embolism, and it's a blood clot gets dislodged from the leg and typically gets somewhere in the pulmonary vasculature, and there's no blood flow distal to the clot. And so the first symptom, I don't have it written down, but the first symptom in like maybe 15-20%, it's a high short-term mortality. First symptom is just dropping dead sometimes. So this is a high short-term mortality. So getting a diagnosis quickly is very important. What's done is you get something called CT angiogram, and that is a CT scan, a high-resolution CT scan with iodine-based contrast that makes the vasculature show up very hot. And so the radiologist will look through the vasculature and look for a clot. So they've identified visually, there's the clot right there, you see it, and so this person has pulmonary embolism. Up to 30% of people aren't immediately eligible for this gold standard diagnostic test because they're either allergic to iodine or their kidneys can't handle it, or maybe you don't know. And so this is a real pain point in emergency centers because you want the quick diagnosis, but then you have to deal with contrast. All right. Another way to do it is to go back to those nuclear medicine scans. And so in this instance, you don't look for the clot itself, you look for its footprint, you look for its effect. So if there's a clot, then distal to the clot, there's no perfusion, then you'll see these wedge defects type of things where you see the effect that there's no perfusion distal. But the ventilation pattern should look pretty much the same, should look, somewhat normal because it's not affecting ventilation per se. It's a blood flow issue. So what people will do is get the perfusion scan and a ventilation scan and look to see if they're different. And it's called VQ mismatch. Let's see what happens. So we did this. This is the patient. I computed perfusion and computed ventilation for a patient who went to the ER who maybe had PE. They didn't know yet, right? And so we looked at the patient. This big cold spot is bad. That's a patient's left upper lobe is not functioning very well. But you see it both in the ventilation and the perfusion. So while this person definitely is sick, it's not PE because this perfusion defect matches the ventilation defect. If it was a PE, then the distributions would look different. You'd have the cold spot in perfusion, but you wouldn't see a cold spot in ventilation. It would be a VQ mismatch. So this is a negative patient. This is a positive patient. So there's a wedge defect in the perfusion, and you go look at the ventilation, it's a weird looking distribution, but it's not the same as this one. And so you can say then that there's a VQ mismatch in this patient, they probably have PE. All right. A next step on doing that was that diagnostic wise, and it's going to require someone to read it and such, and I try within the research that I do to minimize clinical workflow disruptions. So one thing you also could do then is it possible to simulate the CT angiogram that everyone's familiar with looking at from the non-contrast CT scans that I typically get and make my own ventilation perfusion images out of. And so the question is, in these two inhale exhale scans, is the information needed to reconstruct the CTA available to you? And I say yes, actually, because I have all the vasculature in there. You can see that, right? It's a CT scan, it's anatomic. And I think I have perfusion information because I was just able to compute it over here. So I think there's a reasonable chance for me to be able to recreate this image just given these two non-contrast scans. All right. So what data do I have available? Well, I have 7,000 CTA images from patients. I also have about 10,000 of these types of images for unrelated patients. And so, and only 115 where there's a CTA coupled with these inhale exhale CT scans. So that's not enough to do any deep learning, right? And these things aren't related. So how are you going to do that? And I think those who are keeping score at home probably know. So you have to, find some low dimensional representations of both of those image spaces. I can do that using an autoencoder. And once you have this autoencoder, I know it's like, oh, what is going on? It's the flow of information here where we do something called a cyclic GAN. And it's a way of using generative models, adversarial models, to be able to translate from one image domain to the other and back again without having paired data sets. And the reason I have to do that is because I don't have enough pairs to be able to translate CTA to inhale exhale CT. So I'm using a whole bunch of data that's unrelated to each other, but I can use this approach in AI to try to still map those data sets to each other. It's not always the time scale of breathing. So this is over years now. So I would still say this is a dynamic image, but this is mammography now. And 1 year, 5 years, so every couple of years, it's years, so every year for I think up to 5 years, these patients are enrolled in this merit cohort from MD Anderson. And the thinking is sometimes there's a nodule and you can see some of them here, right? And they're identified there. And it's not clear if it's cancerous or not. And so you don't want what they don't want to do is operate needlessly. But at the same time, you need to be sure that you're not missing a disease. So it might look this way on year 1, it might look this way in year 2. The question is, if you take all that information together, that'll better inform your decision as to whether or not something's changed. Maybe it looked like it was nothing in year 1, and then somewhere into year 2, year 3, it's changed, and now something has to be done. This is tricky because the images are in one thing, but they're not annotated necessarily. A radiologist reads it and they put it in a report, right? So, but I have 5 years of reports and I have 5 years of imaging, but it's lots and lots of patients. And so the first thing that we have to do is use a language model to read the radiology reports automatically for us and draw the regions of interest for me. Then once we have the regions of interest denoted from the radiologist report, then it's a separate classification problem that takes the information longitudinally and looks to see whether or not this person is needs to have an intervention. You know, this is another dynamic image. So this is people who have ventricular tachycardia is usually caused by some sort of scarring tissue. And one way to do it is to insert a probe and then heat it up, so ablate it, so fry the scar tissue. That's one way to treat this. A newer way now is to use radiotherapy, because you don't have to stick anything in anybody. The radiation is, in a sense, non-invasive, as non-invasive as you can get. All right, it's radiation still, but the idea then is to irradiate the scar tissue. So it's just like cancer. You draw where you want to shoot, and then you shoot it. The problem is identifying where to shoot. That's the hard part. And so if I watch the heartbeat, then can I infer the material properties? And presumably within the scar, they're going to be different as opposed to the rest of the heart wall. And so that's a collaboration we're doing with the Sachs lab. And that's me, the postdocs, the grad students. It takes a village. I have a whole bunch of undergraduate researchers as well. My collaborators, that's not a coincidence. My little brother, he's a medical physicist, and this is the three of us are PIs on those the lung cancer studies. I'm looking for more collaborators here at UT who would be interested in this type of thing, or want to incorporate some other. Maybe you're better at natural language processing than I am. I'd be grateful for the help. Or if there's anything I could do, I'm happy to do that as well. So I don't know how long I went. It sounds like I feel like I went long, but I'll leave it at that.
Thank you very much, Edward. Very interesting. I actually have a question. The story you told about the patient with esophageal cancer, that was pretty scary, and it kind of reminds me about how I always thought it was so strange that, you know, our current best way of keeping track of cancer and looking for cancer kind of unfortunately increases the risk of that. Is there a solution there?
For for lung cancer, there's solutions. There's low dose, they call it low dose CT screening now for lung cancer, which is a CT scan. You're right. Every time you get irradiated with an X-ray or a CT scan, it does actually increase the probability of developing a disease later. But there's lots of analysis that's done on whether or not it's worth it. So the risk that you get for having, the risk increase that you incurred, is the trade-off worth it to figure out if you have a bad disease right now? And it checks out that it's totally worth it. And so one of the big advances, lung cancer had plateaued for a long time, and in the past few years, the 5-year survival has gone up. And the reason for that is because of the low dose CT screening. So they're catching disease earlier, and it's much easier to treat in that regard. And so there's thinking along those lines. So it still has false positives, false negatives, and then you still have to get bronchoscopies for biopsies and such. So I am looking at that problem as well, thinking that if I can estimate what the perfusion signal is in and around a nodule, then that might infer some sort of vascularization in the tumor, and then, well, maybe if it's vascularized, then it's probably something you need to worry about. And if it's not having a strong perfusion signal, maybe not. But you're right. For the screening stuff, there's been a lot of push to get away from CT scan,
Okay.
or at least lower
But
the dose.
that is good news about the survival rates, because I do believe it's the leading cause of death in cancers, right? On
I
cancer.
think it has the highest mortality. Yeah, it's not the
Right.
most common. That's
Right.
prostate and breast, but I think you're right. I think it still is the largest killer.
Thanks so much, Edward. Are there any other questions?
I have a question. So you talk about radiology report, which is NLP, right? Then you talk about your image. So you say you use language model to get a report and try to identify the location in the image. How you do that? Like you use LSTM, like it's the cross modality.
Yeah, I mean, so inside the radiology report are landmark definitions. So you can imagine, like, this degrees, usually they'll use like the nipple as the baseline landmark, and they'll say, however, this far or in this angle. And so on the NLP side, we're really doing is identifying those directions, that roadmap, and then pointing you in the right direction, and then turning on an auto segmenter that can, based on that seed point, find the nodule that's of interest. And then I'll want to do that at every single time point that I have. And then once you have the bounding box around the nodule, then you can start making a prediction. But there's like 10,000 of these patients. And so manually going in and trying to do this is not feasible. That's why the natural language processing part, it's primarily there just to get me the landmark information so I can identify ROI.
Yeah, but the bounding box can be generated from a CNN, right? When you use the CNN, because each image you have a disease. So if you have CNN that can predict the disease, then they can go back also generate bounding box.
You could. But I want to make sure that because I want to make sure it's the same one. Is the thing, because there could be multiple, or there's one in particular the radiologist is concerned about. I need to identify that one. Does that make sense?
I see. Yeah. I see. Thanks.
All right, just feel like I'm teaching. It's like I must have explained it so well.
Yeah.
Just, yeah, no, that was good. I got it. I got the whole thing.
Yeah.
All right.
So how do you use large language model like ChatGPT?
Oh, just to pull out the token. So it's ChatGPT, and you can convert. So I have the student working on it now, but you can convert the keywords into tokens, and then the tokens we convert to an actual position in physical space, and then we use it's like a seed point generator for now. Just you're right with the CNN thing, but I don't have labeled data is the problem.
But you have a report, right? For each image, you have a lot of report, and this is a text image pair, and yes.
Oh no, the text is one thing. The text is I know what you're talking about. The text isn't in the image. It's a separate report.
It's separate, but still you have an image and text.
Yes.
All the same thing, right? So you can actually, do you know clip, like do you know clip? Clip is it's a computer vision algorithm that connect the image with the captions with the text. So yeah, and you can do the visual question answer use the ChatGPT. That because you have a text, you have the image, then you can ask questions. They can go to the both sides to find. For instance, say how many cells a cancer cell. I'm working with pathology image right now. So can you count how many cells in this pathology image, a cancer cell? And then you go both sides to look, image and text.
Yes, it's exactly what we need. We just need some way to draw the bounding box, and that's the main thing. Then once you have the bounding box, you can do whatever you want for classification.
Yeah, we draw a lot of bounding box, but just only on the image side. So we use ResNet and all the supervised learning whatsoever, but for lung cancer prediction, like 14 of them, not 14, the lung disease. But then use this, we use attention score in the last layer or first layer, combine the neural network, and then you can draw bounding box. But oftentimes this bounding box is way bigger, much bigger than the original it's cover a broader area than the original thing. They have a ground truth, so that's how we can generate the smaller bounding box that exactly the same as a ground truth, because ground truths have the small box, and with your attention model you draw a big box. Like,
yeah, makes sense. I mean, this one, the problem is that those mammography images there's lots of potential places where there could be a nodule, and they might have multiple. So they really do want specifically this one, and they want to track that one across 5 time points, and they want to do that for 10,000 people, and that's But you're right. Anyway, there's lots of ways to go about it. ChatGPT just seemed like the more fun way. I mean, we don't have to do
and
that.
also GPT-4 or 4.5, they will have a cross modality, image and text. So now currently only text. Now they will have a image and text.
Oh, that's right. Yeah, the new one.
In the near future. Yes.
Yeah. I haven't tried that one yet. That got funded. So that study, the breast cancer study, that's another grant with Odin Institute and MD Anderson. There's these $5,000 or $50,000 seed grants for collaborations between Odin faculty and MD Anderson faculty. 25K goes to MD Anderson, 25K goes to Texas, and that one just got funded. So we're starting to data transfer.
Large language model.
What's that? Yeah.
Use large language model.
Yeah.
Great. Looking forward.
Yeah, I'll let you know how it goes.
Okay.
Or I'll ask you to help me. You want to work? It'll be fun.
Yeah. I think we're about time, right?
Yeah.
Yep. So if anyone else has any questions.
All right. Thank you everyone for coming out. Appreciate you and your time.